Hi everyone. This week we're going to try and cover a different type of topic, and we're going to talk about status asthmaticus. So not just asthma in general, but specifically severe asthma. In the following slides, I'm going to try and just take you through a bit of asthma management as well, but we'll try and concentrate more on status. Number one, it's a scary thing when it does come in. The patient is in a lot of distress. Most of these patients require ICU once they do come in. And the management sometimes does get lost on people, or the management sometimes can trip you up if you do it in the incorrect order. So I'm going to try and take you through all of that, and hopefully you'll be able to um, be able to manage these patients when they come in. Now, of course, status asthmaticus is a severe life-threatening condition. It's the most extreme form of asthma that you can find. So in this little table, we just see the difference between mild, moderate, and severe. But we're going to concentrate mainly on severe. So the most important thing is this drop in your saturation. And I must be honest, most of these patients will be around the 80 to 88%. You won't really do a forced expiratory test. The silent chest is probably extremely important, and it's one of the biggest predictive factors I've found that tells you how bad this patient is going to be. So you check each zone, and from there, you basically decide how many zones are involved. So the silent chest is probably one of the biggest indicators of how things are going. And the more zones of the chest, more lobes that you have involved, the worse it is. So I always base my initial assessment on that. So I check, especially the upper lobes. If the upper lobes are silent, that's an extremely worrying sign because it's difficult to plug the upper lobes. It's much easier to block the lower lobes, the middle lobes, but once your upper lobes are silent, that's quite an indication that things are really going badly. Posterior lobe, same story. If the apices posterior are involved, it's quite severe. And what may happen is you may get a combination of presentations. So you may get, for example, one area that's silent, one that's not so bad, so it's only got expiratory wheezes, other areas that have inspiratory and expiratory wheezes. It's good to actually have, documented all of those because it talks to the prognosis of the patient or respiratory effort as the patient gets worse. The patient does have an altered level of consciousness. In fact, it's very difficult to actually get them to cooperate. You often have to sedate them, which is a bit of a problem because they're already struggling to breathe, which shows you how important intubation is. They're agitated, they're confused, they're exhausted, they're cyanotic. So the thing that you need to do is get oxygen into this patient, which is unfortunately quite difficult. And that's why these patients present quite a bit of a challenge. So especially just before the collapse, they'll be in the tripod position, right? They're unable to lie flat because they can't use their accessory and abdominal muscles as well as they would like to. And leaning forward and putting your arms and elbows over the edge, if you try it yourself, you can actually create more force in your breathing. So that's what they're doing, all right? And these are the possible etiologies over there. So as you can see, it's a harrowing experience for the family, for the patient, and for the staff, because this needs to be sorted out within a minute or two. It reminds me of a joke where a person says, technically your life is only, you've only got 2 minutes to live, and every time you take a breath, you hit the reset button, which is actually true, so this patient is running out of oxygen. So you really got to be worried about that. This is just basic pathophysiology. I think most of us who have been through at least 3 to 4 years of medical school should know this. So we're just talking about constriction and inflammation. So the tightening of the smooth muscles, the thickened and inflamed walls, and this is what leads to an asthmatic attack. Now, of course, in status asthmaticus, that's taken to the extreme. Now, this is the algorithm. What I would suggest is, well, the top part just says, is it suspicious of a status asthmaticus? So if it is, you really need to start, considering ICU and things like that. And if it's not, then these are the things that you try and go through. But the initial thing with the status asthmaticus patient is to try and get as big an endotracheal tube in as possible. So the widest diameter. So I've used size 8 tubes on female patients, it's quite a tight squeeze, on a small adult. You use the biggest tube that you can safely put inside. Sometimes you don't even have to inflate the tube because it's so large. But the thing is, the airflow increases to such a dramatic extent that you can actually save the patient's life. So don't go for comfort when you're talking about intubation on this patient. Don't say, okay, it's going to be comfortable for me. No, no, no. Try and get in as big a tube as you can. Now, one of the tricks that we've used before is actually getting in a smaller tube initially. So let's say your patient would adequately take a size 7 or a 7.5. We'd pass that in. Then we'd pass a bougie, or we'd pass an introducer or something like that, so that we in the airway, remove the smaller tube, and then insert the bigger tube on top of it, which actually works quite well. Now, one of the things that we also need to know here is what do we do if we don't want our patient to progress? Let's say we have somebody who's severe or moderate, starting to go on to severe. How do we prevent them from becoming a status asthmaticus or an extremely severe? So the algorithm to follow is first give your nebulization. So your salbutamol, your albuterol, your what was the other one? No. Oh, it just slipped out of my mind. And the other one that we give, okay, just slipped out of me. Anyway, and then we give IV steroids. Now, ideally, you'd want to give hydrocorts, but even if you have corticosteroids like dexameth and things like that, by all means, give it if you have it available, because it's obviously much stronger. The problem is that the time to onset is a bit longer. So the hydrocort tends to work a bit faster, and you can give you can give more doses without causing any or as much problems. Now, the next thing we do is that we give adrenaline subcut. Now, the reason why we give adrenaline subcut is because we have 4 types of receptors: alpha 1, alpha 2, beta 1, beta 2. These are in the smooth muscles. Now, when it's given adrenaline is given in large doses and given IV or IM and things like that, it tends to target the alpha 1s, which causes extreme vasoconstriction, chronotropic, inotropic effects on the heart. But if you give it subcut, it tends to go in more slowly. And it actually then stimulates the beta 2 receptors, which cause muscle relaxation in the bronchial airway. Now, the normal dose is actually 0.3 to 0.5, but I would say go for 0.5, even in a child, unless it's extremely small. And I'll be honest with you, having used it now many, many times, a lot of the patients improve quite dramatically within a few minutes after that. Very often, if I've reached this stage of giving adrenaline subcut, I also add magnesium sulfate. The reason being, what happens is they found in a lot of asthmatics, especially severe asthmatics, they have cell instability due to magnesium deficiency. Now, the exact pathophys behind that is quite in depth. I'm not going to go into that. We'll be sitting here for another half an hour. But essentially what happens is by giving the magnesium sulfate, you're essentially stabilizing the cell wall, especially of the smooth muscle and of the alveoli as well, and of the larger airways, so that you actually increase the ability to reabsorb that inflammatory fluid and decrease their leakage as well. So that it really does make a big difference. And what you'll do is that I normally judge it based on how severe it is. So if it's a severe, moderate severe, and I don't want the patient to get worse, I'll give them about 2 grams in 200 mils, run it over about 20 minutes. But in status asthmaticus, we've given 2 grams over 10 minutes, 2 grams in 200 mils of fluid over 10 minutes, sometimes repeated that again. Of course, you don't want to give too much at the same time because it has its hypotensive effects, but most of the time 4 grams is quite sufficient. And even though you may not get the patient out of status, you'd at least give them quite a bit of relief. Then, of course, we go to intubation as we discussed, and the patient will go into ICU, and they'll normally have inhaled volatile anesthetic agents, and that will be prescribed by the ICU doctors. The other thing that we can do in the emergency department, something that was developed in South Africa, is the asthma hug. So let me just get my video up here. I just want to show you guys. There we go. Sorry. I don't think you can see me over there, but let me just try and get it up and see. Right, there we go. All right, so what you do is that you line up everybody in the emergency department. So from the doctors to the nurses, every single person that you have, because it's extremely exhausting. And what happens is that you have your tube down, you inflate, right? So the patient then expands and then physically push down, right? Push down as hard as possible. So what happens is that you actually force out as much air from the lungs as is possible. Okay, so everybody needs to do that. Now, in saying that, it's let me just put that away. It's extremely tiring. It's not easy. That's why you line everybody up as well, and it does help as well. The other thing I just wanted to mention about intubation, and we're going to get to PEEP just now, but one of the things that you need to do is not just force air into the lungs. So what I normally do when bagging these patients, especially, or whether you've got them on a ventilator, the expiratory time needs to be increased quite a bit. So what would happen is that you would uh, uh, put in a breath and then at least allow 2 to 3 seconds to pass so that you can exhale. Now, this, of course, can be done with the asthma hug as well, so that the patient is getting a forceful exhalation. And we're going to talk about why in a second. Okay. So your investigations are chest X-ray, blood gas, baseline bloods. Here we can see hyperinflation on an X-ray. So the way that you look at this, now, I mean, of course, you can talk about, a bit of infiltrations over there, but you start counting the posterior ribs, all right? So these are your posterior ribs. Remember, the anterior rib is coming around there. So we can say we've got 1, 2, 3, 4, 5, 6, and 6 is about normal. Once you go to about 7, 8, and even 9, then you know you have a hyperinflated lung. What happens as well, you get flattening of the diaphragm to the shape as you can see here. It sort of tense in the middle and then goes away. So this tells you that it's quite severe hyperinflation. Now, one of the other things that you may see, especially the alveoli rupture, and it's not something common, but you may see a line just across here, and I've seen it on a few patients. So what happens is that on either side of the heart, you can actually see sort of like you know uh, uh, like the pericardium also almost lifted off the heart, and that's called pneumopericardium. I didn't include one in here, but pneumopericardium is a sign of very severe status asthmaticus. The alveoli are rupturing, and essentially all that air is being tracked back along the major airways and eventually getting into the mediastinum as well. And it's a major severe sign, something you need to worry about if you do see it. Now, one thing I will tell you is beware the normal blood gas, especially in a severe patient. What happens is that initially the patient has increase in ventilatory effort, PCO2 decreases because they're blowing off as much as they can. They're not in anaerobic respiration, and they become alkalotic. And the reason they become alkalotic is because they're blowing off a lot of CO2. There's no plugging. Then what happens is as they start to get worse, the ventilatory effort increases even more. Now they start retaining CO2 because there is plugging. So because there's plugging of these airways, that CO2 has nowhere to go. Then the patient starts going to anaerobic respiration. And when that happens, now you've got two things that are starting to increase your acid level. Let's just say your acidity, all right, and dropping your pH. So what happens is that you have a patient that's initially alkalotic, and once they start to normalize, you need to be worried, especially if you initially examined this patient, initially saw them, and they were actually mildly alkalotic, and now they start to normalize. That's actually not a good sign, unless the patient is completely symptom free. But this is a sign that things are actually getting worse. And once the patient becomes severe, initially you'll get increased ventilatory effort, you'll have severe tachycardias. And as the patient becomes more and more acidotic and more dependent on anaerobic respiration, you start getting this bradypnea and bradycardia that starts affecting them. Your PCO2 increases rapidly. And based on our values, once the patient goes, listen, if the patient is severe, I've intubated them even when it's at 8 and above, although they do say at 9, but I must be honest, even at 8, based on their GCSs and things like that, your lactate increases dramatically at this point because your patient is almost entirely dependent on anaerobic respiration. And unfortunately, it's a poor prognostic sign as well when that happens. And then your patient will eventually start going into acidosis. So if you see acidosis in an asthmatic patient, really get worried. And of course, the plugging will be present, and the plugging is severe, so that you start to get your silent chests and things like that. Now, when to intubate? So the absolute indications for intubation: severe hypoxia, CPR, severe deterioration, especially in a child. Relative indications: progress of respiratory failure, increased CO2 despite all the available treatment. So PCO2 greater than 45, well, that's in America, we would say over 8 or 9, and once they go over that, then you need to really get worried, But as I say, you don't base it on the blood gas. Your blood gas is just there to help you. It's just to guide you, to tell you, are you doing well or are you doing bad? And the things that you have to track are your CO2 and your lactate. So use the largest caliber you can get, as I had mentioned, and remember to increase your expiratory time. Now, this is especially important if you have a ventilator available in your emergency department. Make sure that your I2P is set to 1 to 3. That's the best thing that you can do. The type of mode that you use generally, it's a difficult one to say because it is patient dependent. But anyway, let's not get into that because that can get quite involved. And the majority of these patients I found don't respond well to ventilations or being on a ventilator. You need to get them into ICU as quickly as possible. So you really need to judge it on your bag. Now, one of the things that's extremely worrying in Status Asthmaticus is what we call auto-PEEP, all right? So positive end expiratory pressure. So normally what happens is when we breathe out, we have an amount of air that's still left in the alveoli. And PEEP is there in order to prevent the alveoli from collapsing. And the reason for that is quite simple. If you ever try to blow a balloon from when it's absolutely flat, it takes a lot of effort. But if it's slightly inflated, it becomes a lot easier to inflate. So that's why we've been, well, it depends on your persuasion, designed or evolved to have PEEP. Now, what happens with asthma and severe asthma especially is that you get air that's coming in through here. Now, the air is there and the air is unable to leave. So you start increasing the PEEP. And you keep on increasing it and keep on increasing it and keep on increasing it, because the more you're breathing and the less you're able to get out. Because remember, when you inspire, when you take a breath, you have dilation of the airways. So whatever plugging is there allows more air to get in. But as soon as you exhale, it goes back down. So these plugs become a lot more. The blockage that they're causing is obviously a lot more. So you start to retain air inside there, and eventually that leads to rupture. And auto-PEEP is one of the more difficult things to actually treat, and it can cause severe complications, I can tell you that much, which is why we make sure that we give the patient enough time to expire. All right. All right. So, I'd forgotten I put this in here. Sorry. I think I just done it a little while ago. So this is actually the pneumopericardium. All right. So I've been busy with quite a bit today. I forgot that I had actually put this in. So this is pneumopericardium. Okay, so there you can see air that's backtracked and is now in the mediastinum and around the pericardium. So this is a very, very dire sign. And it's really something to worry about. Okay, so I hope you guys enjoyed that. Yeah, to all your asthmatics out there, it's not an insult against you. I just found it as a funny joke just to put in at the end of everything. And I hope you guys learned something. And hopefully you'll improve your understanding and your management of status asthmaticus. In our protocols, if you go on to the A&E Learning website, you will find a new asthma protocol, which you can always use. You're more than welcome to use it, and it guides you through each step in a little bit more detail. And it's the type of thing that you can actually use. I've also got an asthma checklist inside there that you could also use as well. Although the asthma checklist may be a bit easier to use in a non-emergent situation, but you can use it in a stabilized emergency patient as well. So I hope you guys enjoyed that. And yeah, hopefully we'll have another topic soon. Keep well. Bye.